My name is Rachel Jackson, and today I'll be going over Precedex. Precedex, or dexmedetomidine, is a selective alpha-2 adrenoceptor agonist with anesthetic and sedative properties that are thought to be due to activation of G proteins by alpha-2A receptors in the brainstem. This activation results in the inhibition of norepinephrine release. With high doses or rapid IV administration, peripheral alpha-2B adrenoceptors are activated, causing vasoconstriction. Here in the NICU, Precedex is indicated for sedation with only mild analgesic effects, which is why it's often paired with acetaminophen or fentanyl as needed. At Northwest, we have the option of intravenous or intranasal administration. Some advantages of this medication is that it's opioid sparing and it does not slow down gut motility. Disadvantages include that it only has mild analgesic opportunities by itself, and it's also quite expensive. So the mechanism of Precedex is shown here with this visual representation. You can see the binding of dexmedetomidine, or Precedex, to the alpha-2 receptor, which is right here. And the binding to that receptor results in the negative feedback to the synaptic vesicle and the inhibition of norepinephrine release ultimately. Some of the pharmacokinetic data for dexmedetomidine is shown here. As I explained, Precedex may be administered IV or intranasally. The onset of action for both the IV loading dose and the intranasal administration is shown here on this slide. The intranasal administration may be a little bit faster than what's shown here with the use of an atomizing device, which we'll talk about in a few slides. The duration of effect of the medication is about 1 to 2 hours. However, the half-life in preterm neonates, those 28 to less than 36 weeks gestational age, is about 7.5 hours. And in term neonates, those 36 weeks above, it's about 3.2 hours. There is an optional loading dose with this medication, which is 0.1 to 0.5 micrograms per kilogram per dose, which is infused over 10 to 20 minutes. However, use of a loading dose is dependent upon concomitant sedation agents and the patient's current and desired level of sedation. In the NICU, we do not typically give an IV loading dose because it can cause hypotension. Maintenance dosing will be a continuous IV infusion of 0.1 to 0.3 micrograms per kilogram per hour, and that's initially, and then you can increase by 0.1 microgram per kilogram per hour as needed to achieve the desired level of sedation. Errors commonly occur due to misinterpretation of dosing information, since maintenance doses are expressed as microgram per kilogram per hour. The reported range in studies for neonates is 0.2 to 0.6 microgram per kilogram per hour, but the maximum dose is 1.5 microgram per kilogram per hour. I mentioned the two options for administration, intravenous or intranasal. For IV administration, if you would like to give a loading dose, be sure to infuse the loading dose slowly over 10 to 20 minutes to reduce severe side effects such as hypotension or even hypertension. For intranasal administration, you can use an undiluted dosage form, which is 100 micrograms per ml, or you can dilute that amount in a small volume of NS to a total volume of 1 ml, then divide the dose and give half in each nostril by slowly dripping it from a needleless syringe onto the nasal mucosa. Or you can use a nasal atomizer, which we'll talk about in a slide or two. And that makes administration very easy. If you do happen to use a diluted solution, it may be stored for up to 4 hours at room temperature or up to 24 hours if it's stored at 2 degrees Celsius to 8 degrees Celsius prior to using it. To use the nasal mucosal atomizer device, it's similar to what you would use if you were to administer midazolam. You remove the needle cap and remove the lid on the vial if it has one. Then you insert the needle into the vial and draw up the prescribed dose of the medication plus an extra 0.1 milliliters by just pulling on the plunger. And then you take the needle off the syringe and you attach the atomizer Then you hold the back of the patient's head really steady with your free hand and place the atomizer into the nose, aiming toward the ears. Then you deliver half of the medication into one nostril by pushing on the plunger, and then you switch to the other nostril and administer the other half of the medication. As far as intravenous administration, you may be wondering about compatibility. Precedex is not compatible with amphotericin B, or pantoprazole, or phenytoin, or diazepam through the Y site, but it is compatible with D5W, LR, and NS. Adverse effects you may see in your patients are highlighted here. Bradycardia and hypotension are associated with rapid IV infusion, which is why we try to avoid IV administration with neonates. Hypertension and tachycardia may also occur, and these are primarily observed during loading dose administration and associated with the initial peripheral vasoconstrictive effects of Precedex that we discussed on the mechanism of action slide. Precedex may also cause electrolyte depletion, specifically with hypocalcemia, hypokalemia, and hypomagnesemia. It's also important to note that patients who receive Precedex for more than 24 hours may experience withdrawal if the medication is stopped abruptly. We will discuss this more in detail toward the end of the presentation. The cardiovascular effects we discussed are the most common side effect observed. To prevent hypotension from occurring, titrate the maintenance infusion no more frequently than every 30 minutes. If hypotension does occur, there are several options for treatment. You could stop or decrease the infusion, increase the rate of IV fluid administration, use pressor agents, or elevate the patient's lower extremities. Transient hypertension has been primarily observed during loading dose administration and is associated with the peripheral vasoconstrictive effects of dexmedetomidine like we just discussed. But treatment of this is not generally required. However, you may reduce the infusion rate, and that might be necessary to do. Precedex is primarily metabolized by the enzyme CYP2A6, which is an enzyme that is inducible by phenobarbital, so co-administration of phenobarbital may speed up the metabolism of Precedex, enhancing the hypotensive effects. Dexmedetomidine is a minor inhibitor of the enzyme CYP2C9, which metabolizes common medications including losartan, montelukast or Singulair, and phenytoin, so these medications may not be metabolized as quickly as they would otherwise. Since we have discussed in detail the cardiovascular effects as well, you may have guessed that Precedex may enhance the hypotensive effect of hypotension-associated agents. So the most important drug interaction to specifically watch out for is concurrent use of beta blockers, since alpha agonists may enhance the AB blocking effect of beta blockers. The monitoring parameters for Precedex are outlined here on this slide. The first thing you want to evaluate is the level of sedation of your patients, and I know that y'all already document that. Also the heart rate and the respiration rates. Also, it's sometimes important to watch an ECG, and I'm sure that the physician would order that, or the nurse practitioner would order that if that were necessary. And also blood pressure, since we've talked so much about the cardiac effects. Other things to think about when using Precedex include patient arousability, tolerance development, and withdrawal. Patients may be arousable and alert when stimulated, and this alone should not be considered as a lack of efficacy in the absence of other clinical signs and symptoms. Use of infusions greater than 24 hours has been associated with tolerance and tachyphylaxis and dose-related increase in adverse reactions. When you abruptly withdraw this medication in patients who have received greater than 24 hours of therapy, withdrawal symptoms may result, and those include withdrawal symptoms similar to clonidine withdrawal, so hypertension, tachycardia, nausea, vomiting, agitation, and headaches. Use for greater than 24 hours is not recommended by the manufacturer. Thank you very much for listening to my presentation. These are the self-assessment questions on this topic.